Consider this: a machine, devoid of empathy, untethered from fatigue, unburdened by ego, gazes into your biology and declares what ails you, not in hours or minutes, but in seconds. A cold, calculating interface offering a verdict on your most intimate vulnerabilities. In a Beijing clinic, this is no longer a parable of the future, it is routine. A patient enters. An AI scans her breath, her skin, her tone. 10 seconds later, a diagnosis. But beneath this technological marvel lies a deeper disquiet. When the human body becomes data, what happens to the soul of care? In this exploration, we will peel back the sleek facade of AI medicine, not to condemn or celebrate, but to examine. What are we really asking of these machines? And what, in turn, are they taking from us? The allure of AI in medicine lies in its promise of omniscience. Trained on millions of data points, CT scans, retinal images, heartbeat patterns, coughs parsed into waveform fingerprints, these models do not think in the human sense. They recognize, they correlate. They wield a form of pattern recognition that, paradoxically, mimics intuition while being entirely mechanical. Google DeepMind's ophthalmologic AI, capable of diagnosing dozens of eye conditions with a keystroke, does not understand vision. It understands statistical proximity. Cure.ai's chest scan software does not see tuberculosis. It calculates the probability of visual congruence with disease-labeled data. In essence, AI doesn't heal, it predicts. And prediction, as we know, can masquerade as knowledge. Yet the speed is seductive. A Stanford-led initiative trained neural networks to detect COVID-19 by analyzing involuntary coughs, subtle sounds beyond human perception. Efficiency is no longer the bottleneck, but the question lingers. When speed becomes the standard, what nuance do we forfeit? We risk reducing diagnosis to transaction, from the ancient art of listening, probing, interpreting, to a sterile output. A name on a screen. We may gain velocity, but what do we lose in the erosion of relational care? It is tempting to see the machine as the ultimate arbiter, immune to bias, detached from fatigue, incorruptible by emotion. But AI, for all its supposed objectivity, is only as unprejudiced as the data it ingests and the society that shapes it. Bias here is not a glitch, it is embedded. AI trained on dermatological images, predominantly from light-skinned patients, exhibits markedly reduced accuracy for darker tones. In other words, the machine inherits the blind spots of the medical-industrial complex. We have not eliminated prejudice, we have automated it at scale. And yet, the numbers tell a compelling story. AI diagnoses correctly 82% of the time, compared to 72% for human doctors, according to the Lancet Digital Health. But what does correct mean in a field shaped by ambiguity and variance? Diagnosis is not always a binary. It is often a narrative. To treat it as a mathematical certainty may give us comfort, but not always truth. Even more troubling is the displacement of accountability. When an AI misdiagnoses, where does the blame land? The developer, the dataset curator, the attending physician who deferred to the algorithm's authority? The fragmentation of responsibility is not just a technical issue, it is an ethical void. In the rush toward efficiency, we are not merely restructuring medicine. We are reconfiguring liability, trust, and the locus of human judgment. Imagine a world where healthcare is no longer a place, but an app. Your smartphone listens to your breath, scans your face, parses your words. The diagnosis arrives with the same casualness as a food delivery notification. In Kenya, this is not imagination. It is already operational. In Bangladesh, rural villagers receive AI-based health assessments miles from the nearest hospital. Access expands, equity improves, but something else contracts. The human physician, in all their fallibility, brought with them something irreplaceable: presence, the comfort of eye contact, the reassurance of touch, the subtle moral weight of being seen. When diagnosis becomes algorithmic, what becomes of the experience of being ill? Does the absence of empathy affect outcomes or merely emotions? And does that distinction matter? Moreover, we risk entrenching new hierarchies beneath the veneer of democratization. AI tools may be accessible, but who owns the platforms? Who trains the models? Who profits from the data harvested in moments of vulnerability? The promise of decentralized care may conceal the consolidation of medical power in the hands of tech conglomerates, accountable to shareholders, not patients. We stand at a precipice, not of technical capability, but of cultural transformation. The very grammar of medicine is shifting, from relational to transactional, from interpretive to predictive. In this new grammar, does the patient become merely another input, another data point to be optimized? We are entering an era where machines whisper diagnoses before we've even articulated symptoms, where illness is anticipated, predicted, and labeled at the speed of code. The promise is monumental: lives saved, disparities reduced, systems streamlined. But alongside this promise lurks a question too few are asking. What does it mean to be cared for by something that cannot care? AI doctors challenge us not only technologically, but philosophically. They force us to reconsider what we value in medicine, not just accuracy, but attention, not just outcomes, but meaning. As we entrust machines with our most intimate truths, we must ask ourselves not simply what they can do, but what they should do. And perhaps more unsettlingly, what they will change in us long after the 10 seconds are over.